title of my presentation this morning is Diabetes Management for the Elderly in Ramadan. Yeah. My financial disclosures are that I have been speaking on behalf of the following 4 pharma companies. Yeah. I'm just out of curiosity, not sure if any of you realize that WHO has has stated that October 1 as the International Day of Elderly People or older persons. Yeah. Now, if you look at data that comes from United States, yeah, those who are patients with diabetes above the age of 65 have double the risk of major cardiovascular complications. Yeah, and so this is something that we need to consider whenever we are dealing with elderly with diabetes, especially with regards to the need to fast during Ramadan. Similarly, when you look at their risk of diabetes complications, retinopathy, nephropathy, the risk is more than double. And if we're to look at the various age ranges, you'll notice that those who are above 75 are more at risk of complication compared to the those say in the age group of 65 to 74. Yeah, so perhaps in dealing with elderly patients, it is important for us to segregate them in terms of those between 65 to 75 and those above 75. Because as you can see from this data, those who are above 75 are obviously have a higher risk compared to the elderly, the young, so-called young elderly, those between 65 to 74. Yeah. Now, the thing about older patients with diabetes is that they've got several peculiar, rather specific predisposition or risk factors. Yeah. Of course, most important of all is they may have functional disability. Yeah. They can have depression, and of course, in addition to age-related memory decline, you can also get cognitive dysfunction as a result of other primary pathology or as a result of, say, vascular disease from long-standing diabetes. Elderly patients are also prone to fall and fractures, especially if they were to develop hypos and cause CV disease, cardiovascular disease, as well as cancer tends to occur more commonly in the elderly. So these are some of the aspects that we need to consider whenever we deal with elderly with diabetes. Yeah. Now, of course, we refer to the dalil from the Quran and hadith on fasting in elderly. Permission or excuse have been granted to them as evidenced by this by Surah Al-Baqarah, verse 184. Yeah, and we stated that as for those who can fast with difficulty, those who fast with difficulty, they have a choice either to fast or to feed poor individual for every day that they miss the fast. Yeah. And similarly, Ibn Abbas radiallahu an, who commented on this verse, interpreted as a concession granted to all men and women who are able to fast but with difficulty. They have the option of not fasting, and they only need to pay feed the poor, fidyah. Yeah, and Anawi said that the above hadith is Hasan. Yeah, so this is also the fatwa of several of the other companions of the Prophet sallallahu alaihi wasallam, including especially Ibn Abbas radiallahu anhu. So there is Quranic as well as Sunnah justification for elderly patients to be excused from performing the fast in Ramadan. And similarly, if those dalil is not enough to convince elderly patients not to fast, of course, then we need to bring up the understanding of the Maqasid Sharia, the objective of Islamic Sharia. I'm sure all of us are aware that the objective of Islamic Sharia or Islamic jurisprudence can be chiefly divided into 5. Most important of all is protection of religion, followed by life, nafs, akal, intellect, mind, as well as family lineage and property. So if fasting were to endanger one's life or one's intellect, say from recurrent hypos or say from hyperglycemic state or acute hyperglycemia such as DKA or HHS, then fasting becomes, if these elderly patients were to continue to fast, then they would, in a way, committing sin. So this needs to be emphasized if you feel strongly that those, especially those in a very high risk and those high risk individuals would insist on fasting. Right. Now, this is the category that Dar put up many years ago before the recent revision. And if you're to look at the old category, the old risk stratification, you notice that elderly who have, I'm sure you all know that elderly tends to have renal insufficiency, and they are the ones who have advanced macrovascular complications. They tend to live alone, and and in most countries, especially in third world countries, their only means of controlling blood sugars are insulin and sulfonylurea, and they may have other comorbids, and they may be, especially those who are got psychiatric or neurological condition, they may be on drugs that may affect their conscious state. So this used to be a group under high risk. However, with the recent revision, did by the Dar committee, you notice that old age has now been moved from just high risk to very high risk, whereas renal impairment are then split, So this just shows that that Muslim physicians and ulama, feel that old age by itself, it should be, especially with ill health, old age with ill health, they should be categorized under a very high risk, and therefore every effort should be made to discourage old age patients with ill health from fasting, as it can be detrimental, as it can be bad for their disease as well as for their life. And so the guidelines have also specified special population that we need to pay particular attention. Pregnant women have been dealt with by Dr. Sarah just now. Now the other two special groups are that of type 1 and elderly. And when it comes to type 1, the recommendation is that we need to assess their functional capacity. That's number one. Their frailty, or what we refer to as functional capacity, as well as their cognitive function, or their risk of dementia or memory impairment. Now, so two main domains we need to employ to assess elderly patients, diabetic elderly patients, especially when dealing with the permissibility or the safety of fasting. Number one is to assess their functional capacity, whether they are frail. The term is frailty, which is a combination of various characteristics like fatigue, weight loss, restriction in mobility, and strength. And at the same time, we also need to categorize whether they have dementia, or because dementia can be divided into mild, moderate, and severe. So we'll go through quickly into some of this. Now, the most utilized frailty score is that one developed by Dalhousie University in Nova Scotia, Canada. We divide elderly into 9 categories of frailty. And the first 5, if you look on your left-hand side of the slide, they are categorized based on decreasing activity. First 1, 2, they are still independent on their own. But once they go into category number 3, their activity began to be affected, and then you look at the photos beside the description of the categories, you can see very well. It is kind of, the photos are kind of descriptive. You look at category number 4, for example. Is a photo of someone with a walking stick, and of course number 5, the frailty increases further, and that to result to a frame. And then number 7, 8, 9, which are more severe, need a wheelchair, and of course, 8 bedbound and 9 terminally ill. That means their life expectancy is hardly 6 months away. Yeah. Now, I find this interesting. Perhaps Dr. Hasanain, who is in the Dar committee, may consider in the future revision of the guidelines to incorporate these frailty categorization, because as you can see, they are divided into 9, and in the first 3, essentially they are considered low risk. Yeah, for example, category number 3, they got medical problems. Yeah, it's just that they are not as active as before. Yeah, so that may be all this. The first 3 may be considered under moderate or low risk. And then you have the second, the middle panel. Yeah, you see those with can be perhaps be lumped under high risk because slowly their activity is being impaired and they need support. Yeah, physical support as well as support from relatives or friends. And of course, the very high risk are those who are totally dependent on help of others to sustain their daily living as well as their medications. Yeah. So now I want to quickly move into a dementia scale. Because when it comes to assessing cognitive function among elderly patients, normally most of us are familiar with the mini mental state examination. Yeah. But of course, it has less sensitivity and specificity with regards to diagnosing dementia. Then you have the other second popular one, that's of Montreal Cognitive Assessment. That's also less named, but over the last few years, this dementia scale, which originated from Japan, is becoming more and more accepted. Yeah, in fact, it's been just like the frailty score, it's been translated even into the Arab. It's been slowly utilized throughout the world. Because the lovely thing about this dementia scale is the fact that they look at various aspects of dementia, and they look at 13 aspects of it. So it's rather encompassing. Yeah, it's not just dealing with cognitive, but it also looked at behavior as well as things related to daily activities. So it looks at 3 domains. Yeah, it looks at cognitive/memory. It looks at behavioral changes. Yeah. So for example, this is one of the domain number 8. Yeah. How is the patient's reaction when they don't get their wish? Yeah. See, for a lot of us, especially lay people, the fact that somebody suddenly becomes violent or rude may not signify the beginning of cognitive dysfunction. Yeah. But this is one thing that I like about this dementia score, is because it deals with even behavioral problems that may suggest, that may herald the onset of dementia. Yeah. Okay. Now, I'm just going to quickly deal with some studies done on Muslims, elderly Muslims with diabetes, with mainly diabetes, who fast in Ramadan. See, over the last 10 years, or in fact, over the last 15 years, there's only been 3 studies. Yeah, only been 3 studies that specifically look at elderly who chose to fast in Ramadan. So this is the first one that I'm going to discuss. This is a study that was done in Tunisia back about 10 years ago. Yeah, you look at their demography of the patients. Primarily the objective of the study is to look at metabolic parameters in patients elderly with cardiovascular risk factors. You look at their CVD risk factors. Majority of them have got hypertension, half got diabetes, as well as dyslipidemia, etc. And interestingly, you notice that 1/3 of them are on diuretic while fasting at the same time. In general, the patient tends to be a bit older from the next 2 studies. 71, men and women equally divided. And what happened is when they look at the various biochemical parameters, clinical parameters, the only thing significant coming out of the study is, of course, obviously, the caloric intake that is significantly reduced during Ramadan compared to post-Ramadan. And in terms of biochemistry, creatinine, GFR, urea, these are the ones that are significantly affected during Ramadan. And so this is one of the reasons why we need to be very careful if our patient has got CKD, especially those with proteinuria, because as we know, the presence of proteinuria in someone with CKD projects 3 times greater duration compared to those without proteinuria. Now, the next study that I quickly want to discuss is that of a study done in Mansoura in Egypt, done by the investigators in Mansoura Hospital as well as in the UC Hospital. And you notice that demography of this patient, they tend to be a bit younger. 50% of them are just between 60 to 65. But interestingly, though, nearly 2/3 of them are illiterate. They're illiterate. Notice they can't read and write. So this is, I thought this is unique because at this day and age, we still have quite a number of Muslims who are still illiterate. And of course, 2/3 of them from rural areas. And what is also noticeable is the fact that 1/4 of them lives alone. 1/4 of them lives alone. So let's see. They tend to be a bit more serious compared to the Tunisian study. 3/4 of them got diabetes, and look, nearly half of them have got coronary artery heart disease as well as heart failure. And to my surprise, 1/4 of them have got compensated liver cirrhosis, or perhaps the investigator meant compensated chronic liver disease, because cirrhosis, after all, is surgical diagnosis. And you notice that nearly 3/4 of them are on insulin, and the same number, same proportion are on thiazide diuretics. Now, when you look at the parameters that they investigated, effect on BP and BMI, fasting has the ability to drop BP, both systolic and diastolic. But in terms of general health, you notice that, despite our concern about elderly, especially elderly with CVD risk factors, or even with CVD, as in this case, you notice that their anxiety score becomes less. All this, they become less anxious, they become less depressed. The only thing is perhaps social function is just a bit changed there. So you look at depression, the number of people, elderly with CVD risk factors, when they choose to fast, because all these choose to fast, you notice that they tend to feel better. The depression level drops. Normal. You look at the mild, moderate, they all tend to drop. So which means that when dealing with the need to fast, we also has this one aspect that we tend to overlook: the psychological well-being that will come about as a result of adhering to this spiritual practice. And if you look at what they viewed as their health, mental health, all of them felt that Ramadan fasting did them a lot of good. The number of those who after Ramadan felt very good increases significantly throughout all the assessment. Okay. So finally, I'll just come quickly to management. This is my last slide. I think when dealing with elderly who wants to fast, there are 3 things you need to look to whenever you decide in terms of their medications, in terms of their insulin. Number 1 is whether they are frail, as we have discussed before, whether they have any cognitive dysfunction, and therefore you should limit or you should avoid certain drugs, as in this case, sulfonylureas, etc. Then you also need to look at whether they got advanced renal failure. Those who are in CKD stage 4 or 5, the number of drugs that are available to them are rather limited. They are confined to primarily DPP-4 and insulin. These are, of course, insulin you need to put a lot of emphasis on basal rather than prandial, etc. Now, finally, cardiovascular disease. Of course, when discussing about cardiovascular disease in elderly, we have, of course, numerous recent data to show the benefit of RA as well as SGLT2. Yeah, bear in mind when our group have done a study on SGLT2, yeah, and we find that SGLT2 given at iftar, we tend to minimize the risk of dehydration. Yeah, so there's something that perhaps we need to consider. Okay, now for those who are interested, actually, quickly, yeah, there is this very detailed guideline for elderly with 3 different degrees of frailty published recently. It's available on the website. You can see the website guidelines .co.uk. So this is very detailed. It's one of the few detailed guidelines in terms of diabetes management that deal with the 3 different categories of frailty. Yeah? This one shows mild frailty, followed by moderate, followed by severe. Primarily, they divide into 2 A1C target, those below 10.5, those whose A1C is above 10.5, and they deal with the various complications and the need to titrate them accordingly to avoid hypoglycemias and worsening of CV or renal complications. So with that, my conclusion is, in summary, elderly with diabetes and Ramadan, we must, most important of all, before anything else, is to make every effort to discourage elderly who are in very high risk or in the high risk categories from fasting. Yeah, we need to make them understand that fasting can endanger their life and thus goes against deen, against religion. Then those who opt to fast, yeah, we need, of course, being at high risk. Those who insisted on fasting, their patients as well as their caretakers needs to be adequately trained on safe practices. And finally, I think it is important whenever we deal with elderly, either Muslims or non-Muslims, especially those who want to fast for Ramadan, that we assess their functional capacity in terms of their sterility categories, as well as their cognitive function, to ensure that they do not have dementia. With that, I'd like to thank all of you. Jazakumullah for listening to the presentation.